Thank you. And so I have a very tough act to follow, following two great experts, Dr. Vaught and Dr. Duhigg. And I think the reason that I was asked to be part of this presentation was to talk about how it is that I, trained as a general pediatrician, became a provider of medication-assisted treatment in family units. And so this is sort of thinking about family-centered primary care approach in medication-assisted treatment. This is a striking slide. This is the rate of neonatal opioid withdrawal syndrome being treated in New Mexico at current time. And New Mexico is ahead of the U.S., approximately 14 babies per 1,000 being treated with neonatal opioid withdrawal. And if we think about the number of babies who require treatment, it's about half of those who have opioid exposure. So we're really talking about 30 in 1,000, or 3 out of 100 pregnancies in New Mexico identified with potential opioid use disorder, and half of those requiring treatment for neonatal opioid withdrawal. Now, this rate is just going up incredibly fast. And when I started the Focus program back in 1990, we were aware that we had a number of women who were using opioids. But the problem was we could not figure out how to connect their treatment needs with the care of their children. And so we were seeing the kids and doing a lot of things, taking care of shots, making sure they were growing. But it became very clear to me that if we could not begin to affect the life course of the family, we could give kids shots until we were blue in the face, and if the parent died at an early age, that was going to leave the child and family devastated. And so we needed to figure out how to address the issues of chronic health conditions and also how to address issues of limited treatment access. We started primary care for mothers in 2006 so that we could begin to take care of things like preventive care for abnormal pap smears, so we could begin to think about how to address overweight obesity issues. We included healthy adult screening in our primary care, and the volume became so great that I had to convert from being just a general pediatrician to becoming the oldest family medicine resident in the UNM program. And so I say this with a great deal of gratitude that my faculty colleagues in family medicine have been incredibly great teachers and very gracious about my gaps in knowledge. But in reality, most of us grown-ups are just big kids sort of in bigger bodies, right? So buprenorphine became an amazing reality for us in 2012. And of course, key people, some of whom are sitting on the stage, authored this publication about treatment guidelines in New Mexico. And incredibly grateful for the opportunity to, as a primary care doctor, begin to take an actual primary meaningful role in the treatment of families relative to opioid substance use disorder and other substance use disorders. So here's how our clinics work. We make an appointment for a parent, and at the same time we schedule a newborn visit. So babies are discharged from hospital, and we'll schedule an appointment based on hospital needs for the baby to be followed up. But if the parent, mother or father, have medical needs that we can address, we'll try to bring them into clinic at the same time. We see a lot of women who are being treated in Milagro, the program for comprehensive prenatal care and substance use treatment. Most of the women are on buprenorphine Subutex during the course of pregnancy because that's the medication that's approved for use in pregnancy. And when they transition their MAT to Focus, then we begin to convert to Suboxone. Sometimes that Suboxone conversion occurs in the last prenatal visit in Milagro, and then we begin to basically a warm handoff into our primary care model. At the time they start care, we ask them to complete a contract for primary care, including MAT. And we have a protocol that we use in our primary care visit. And this is what makes it possible for us to basically, in our clinics, we're scheduling between 20 and 30 individuals per half-day session, usually seen by 2 attendings and some residents. And of those patients, 2/3 of them are adults coming for either adult primary care or MAT treatment. And what makes this work is that we have a protocol for the visit to make us more efficient. We review the PMP and the few days prior to the visit. We have a patient-completed questionnaire that's really screening patients for issues of anxiety, depression, sleep problems, craving, and withdrawal, asking them themselves how they're treatment process is going, what's working for them, not working, and really asking them to tell us what we can expect to see in the point of care urine drug screen that we do in clinic. The goal of the urine drug screen is really not to decide whether or not to continue treatment or throw somebody out of the program. It really has to do with creating the context for a conversation between the patient's understanding of their substance use disorder and what we're detecting chemically. And when the two things come together, that's great. That leaves us room to ask questions like, so I see your screen has marijuana in it, and you were talking about that. What does marijuana do for you? Why is it helpful? Is it helpful for sleep? Is it helpful for dealing with anxiety? Are there things that we could think about pharmacologically that could help you sleep that would be A, covered by Medicaid, and B, not create problems with your probation officer? And a lot of times as we begin to explore those possibilities, we find that patients are willing to think about pharmacologic alternatives to illicit drug use. We also confirm home visits for our early intervention team. And so part of FOCUS is a home-based early intervention team that's looking at the babies, young kids, and families where there's substance use disorder. And we think that this is a critical component of the work that we do because basically what we're thinking about as we're providing MAT in the primary care setting is that we're really looking at the development of two brains, the brain of the parent and the brain of the baby, developing in parallel. And if we can bring those developmental trajectories into synchrony, then we think that we have a better chance of protecting the baby for an adverse childhood experience of living in a home with a parent who has a substance use disorder, which leads to potentially all sorts of bad outcomes, including the risk of child abuse and neglect. But secondly, in the development of the adult as a parent, what we're doing is beginning to accelerate their ability to take responsibility and to create a consistent home setting for their infant, which is very much tied to the social constructs of recovery and overall health that needs to happen in the family system. And we talk to families over and over again about the fact that their participation in treatment is a role model for their kids, that what they're doing by their actions is saying to their kids, when things are really tough, when I've been at the very worst time of my life, you came into my life, and these are the things I'm willing to try to do for you in order to make things better. And in doing so, what that's saying to the child is that when they themselves run into these difficult times in their later life, they have a role model for how things worked out, how their parent was willing to go to very important processes in order to make life better for both of them. So I like Dr. Duhig's thoughts about putting our arms around people. We think what we try to do in focus in the primary care model and the extended medical home is we think about our team putting our arms around the people we take care of, and basically in that process pulling ourselves closer to them and pulling them closer to us, because we think that that whole model of trying to get to know people well enough and to engage with them in their life process around important things like the life of their child allows us the kind of connection and engagement that then leads to the possibility of big changes in behavior, and these small ripples of changes, like getting up every night to make sure the baby gets fed, are the kinds of consistent behaviors that lead long-term to a more consistent health process, and for the child, a better likelihood that they will have the kinds of outcomes that the family wants. I say this fairly often, but parents in the process of care, I'll ask them what they want for their child. And it's just striking over and over again. What they want for their child, a lot of times they'll say, well, I want my kid to graduate from high school. Great, and they know that I'm kind of an education nerd, and I want their kid to graduate from high school because in the public health model, if their kid does that, their chances of having economic viability, their chances of having long life, better health are increased. And so the alliance that forms is when I ask them, so what is it going to take for you to see them walk across the stage 17 years from now? How will that look for you? And what is it we can do in this visit today that will increase the chances that you'll see that happen? And then let's make that next appointment next month or 8 weeks or whatever, and let's talk about this again to take the next step. And so we are committed to the issue of continuity, we're committed to the issue of engagement, and we're committed to the idea of basically health for the entire family system. So that's how we kind of think about doing this in the primary care model. And for those of you who are considering becoming primary care providers in the issue of MAT, I would encourage you to think about the family system around the individual you're trying to treat, because I think that's going to be a critical lever to help people actually make good decisions. And also, it changes us as providers to begin to have that level of commitment to a larger family system. So thank you very much.